But we continue with the third case from the Dr. Frankie Tam about the CTO skin for non-CTO complication. So, Frankie.
Yes, thank you. So my honor to be here to share this case to you. So I'm Frankie from Hong Kong. So thanks for inviting me. So I'd like to show a case of complication and how to use CTO skills for non-CTO complications, right? Okay, no new disclosure. So this is a 55-year-old man, smoker, history of peripheral artery disease. He actually presented with class 3 and 4 heart failure, right? So echo, very poor EF, dilated LV, global hypokinesia. At that time, coronal angiogram already showed very severe left main vascular disease. So triple CTO, LAD, third RCA CTO, and we perform a SPECT scan, a FADM scan, which shows a perfusion defect in the apex and anterior region, right? So actually, the indication for revascularization here for this patient is obviously borderline because of the revived BCIS trial. So we start the medical treatment first, and we implanted the ICD in July 2024. Right, so this patient was referred to CTS, however, CABG was declined due to poor targets. He was admitted for recurrent sepsis, recurrent VT, VF, prolonged hospital stay. He was considered for advanced heart failure therapy, but however, he was rejected for heart transplant and LVAD, right? So at that time, after detailed discussion, we are discussing whether we want to proceed to PCI. And because of the poor EF and complex anatomy, we plan to have an MCS, this is impeller assist PCI for this patient. And mind you that this patient has a very bad peripheral vascular disease. So we perform a CT scan, actually show there's a CTO in the left common iliac artery. Right, this want to show you the echocardiogram. So you can see that the LV is dilated, very poor EF, and you can see EF and just 20 to 25%. All right, so these are the peripheral angiogram. I just want to show you. So very diffuse peripheral artery disease. You can see the occluded left common iliac artery and diffuse disease in the right common iliac. We also have some angiogram of the both sides of the axillary artery because we plan to do an axillary impeller assisted PCI. Okay, also want to show you the angiogram, which is I would say is quite very bad disease. So you can see very diffuse disease, osteo-LAD with severe stenosis, which followed by a CTO. Can you help play the video again? Okay, good. Okay, you can see the third CTO with left-to-left collaterals. Again, very diffuse disease. Okay, next slide. This is another wheel which shows again very diffuse disease, LAD CTO and third CTO with left-to-left collaterals. How about the RCA? Let me show you the angiogram to the RCA. Okay, so again, RCA, proximal RCA CTO with right-to-right collaterals, right? And mind you that, remember we have performed a SPECT scan which showed that the only ischemic region is probably in the LAD territory. So in this case, we plan to have a PCI to the LAD CTO. This is also another view of the RCH. When we engage the conus branch, actually there's some more collaterals going to the more proximal side of the LAD. All right, okay, so this for this patient, we ask the surgeon to help us to do an X-ray cut down at the graft, and then we use a single access technique from the axillary artery. So we put an impeller through the right axillary and a single access technique from the right axillary as one access. We also have a femoral 7-French access to do the bilateral injection. For the whole procedure, it was performed under local anesthesia, under conscious sedation with end-tidal CO2 monitoring. All right, so this is the bilateral injection. Okay, can you have to click play the video? Excuse me, can you have to click play the video? So this is the bilateral injection. So you can see that actually we engage the conus branch, which shows a collaterals from the conus to the LAD. Can you keep playing, please? Okay, so the LAD CTO not very long, right? But there's still a CTO there. All right, so we attempt integrated approach for this CTO. We try integrated approach. So we attempt multiple wires, integrate parallel wire with Gynex 2, Gynex third, CB12, or even CB820. But because there's a hard plug just started from the just distal to the first diagonal, so actually you can see the wire just at the subintimal space, but cannot go to the mid LAD. But luckily, with some luck, we have another wire. Okay, so we have a wire re-entry with a Gladius EX. So the Gladius EX luckily goes into the mid LED CTO, which enters in the true lumen, right? Although this is not a perfect CTO, but we think this should be okay because the septal branch is collateralized. So we decided to accept this CTO crossing. Okay, so and then we do our usual fashion, ballooning, gel balloon technique. We put the balloon to D1 and stand the LAD and also port the proximal LAD. However, at this time, problem comes, right? Suddenly the patient complains of chest pain, all right? You can see the pulse pressure reduced and also there's a ST change, which is quite alarming, right? So we do some, can you play the angiogram for me, please? Excuse me? Okay, you can see that actually the cert now closed down, all right? So you can see some haziness is the distal left main, and ACT was 300 seconds. Please keep on playing the video. All right, you can see the cert closed down. So this is a very troublesome situation because these patients are very bad EF to start with. If you do nothing here, probably the patient may not survive the procedure. Right, so what can we do now, right? So, right, so first we suspect it's acute vessel closure with some foam bus. So you can see the flow down to the LVD insert is not that good. Can you play the video for me, please? Right, okay, so we give some integralin, we attempt aspiration from back to me, but still the flow is not that good. And persistent ST change, pulse pressure reduced. So this is a very tough situation now. So what will you do? Further aspiration from back to me, and we just wait for the cord to result. So on the angiogram is actually what is in the beginning, all right? So what will you do? We will perform the third CTO. If you want to do, you do antegrade or retrograde or do ivoscatter entry. Remind that if you want to do retrograde, you have to do it through the epicardial collaterals, and now the patient is on integrity infusion. And also the patient is in shock now, right? Chest pain, you have to do this in a very, very quick way. So this is a very, very dire and also very bad situation. So in this case, because at the beginning we don't want to touch the third CTO, but now we have no option, but we have to perform the third CTO. Right, so we have to do this quick. So we use the epicardial collateral. So we use a 150 caravel sulfur wire. Luckily, the sulfur wire just fly through the ipsilateral epicardial collateral to the distal circumflex, and the caravel microcatheter cross to the distal cert. And then after the caravel go there, we use a retrograde Gladius EX wire to go to the CTO body. So this time we want to be quick, so we just want to go subintimal, right? So we can see the wire just knuckle back to the proximal cert. And now you can see on the right side the Gladius knuckle to the proximal cert. We are very confident that now the wire is in the subintimal space. Using this as the marker, then we begin the antegrade approach, right? So antegrade, we puncture with a Gynix 3 using the knuckle as the marker. And on the right side now you can see that the Gynix 3 just go inside the third CTO body, and the two wires seems dancing together with each other. All right, and then the antegrade wire we switch to a Gladius Mongo and knuckle down, right? So this is what the European or US style of CTO, right? Quick knuckle, go in the subintimal space so that you can perform this CTO in a very, very quick manner. So now on the right side, the video, you can see that both wires in the same space, very close to each other, and then we will do the reverse card. Okay, we do the reverse card with a 2 balloon, all right? And because the two wires are in the same space, though, we use the reverse card with a CM black wire, and you can see the CM black wire just fly through quite easily and go to the LAD. With some manipulation, we pull back the CM black wire, take a turn, and then the CM black wire go into the guiding catheter. So all these can be finished in a few minutes. All right, so because now we have the single access, so we perform the rendezvous. You can see the CM black wire now go to the antegrade corsair, and the corsair go down to the circumflex, and then switch the wire to the antegrade, and then we perform the PCI in the usual manner. All right. Okay, so some ballooning, and after some ballooning, you can see the flow. Now actually we gain the flow back to the circumflex. So now the ST change improve, chest pain improve after the third flow restored. All right, so of course, because the SIRT is so diffuse disease, we don't want to put the stents in the circumflex. So we just DCB the whole circumflex, and then we stent leveling the LAD to finish the whole procedure. So that's the final shot, right? All right, these are the final shot of the angiogram. Okay, so we got Timothy flow down from the left main to the LAD and left main to the circumflex. And the patients are clinically hemodynamic improved. All right, so the impeller V knob in the cath lab and the right axillary wound closed by the surgeon. The right femoral hemostasis by manual compression. And actually, at that night afterwards, the patient have acute lower limb ischemia. So we can see that even a 7 French guiding catheter caused ischemia in the right foot. And luckily, it was vacuumed very easily by the vascular surgeon with embolectomy done. Right, so ladies and gentlemen, in conclusion, acute vessel closure is a dreadful complication, especially if the patient has a very bad EF to begin with. And MCS as this PCI buys time for management of severe complications. So imagine that this patient, if we don't have an impeller, probably the patient with cardiac arrest on the table. And CTO skills may be needed sometimes, even in cases of non-CTO PCI, right? So of course, in your lab, it is better for you or someone in your institution to learn how to perform CTO PCI. So thank you very much.
I think this is a super challenging case. That means during the shot, you did not see any fault in the shirt, and then you can perform the retrograde wiring.
Yeah, so we use the angiogram at the beginning as a roadmap.
Wow.
And by feeling, yeah. So it's very, I would say, a little bit heroic act because in the beginning we don't want to touch it. We don't want to touch a CTO, and now the patient in shock or already on integument infusion, and then you have to touch the epicardial collateral. But we have no other option.
It's not a job with a little bit courage can do. You need really have a big courage and
Yeah,
big
but
heart.
sometimes no option. You have to do what you have to do.
So if you back again, then should we do rewire the cert before you do the LED?
Well, but the problem is even we rewire the cert, right? We still it's just a proximal cert. There's still CTO down there.
But what is the mechanism of no fault?
I think probably there's too many devices going on there. Maybe some foam burst or emboli. I think that's the most likely reason. Although we check the ACT, but that's still possible. Yeah.
Yeah, just for discussion's sake, I don't have experience too. Do you think if we use HDR in this scenario will help? You just put the microcatheter at oxygen and then inject forcefully. Will this open a trap for you?
But you still have to go into the CTO body. The problem is this CTO, if you just do antegrade, there's a proximal cap ambiguity. We don't know where actually is the cap up there and the proximal CTO.
Okay.
So in this retrograde is still the quickest way to secure here.
Just curious. I'm not asking about the technically. You are really great, did a great job. So I don't know what this Hong Kong. Among the patient with the low ejection fraction and look like the akinetic like that. The trial revive BCI2 showing there is no benefit to do
this
vascularization in this
actually-
kind of patient. So what is the
So
consideration?
So in the beginning, actually, we do not offer PCI for this case. You can see actually there's maybe at least a few months after the first diagnosis of the heart failure. So we have the angiogram, we have the phantoms, the SPECT scan. We refer the patient to the surgeon, and I agree that the indication for PCI in this case is not that strong. I mean, it's borderline. Even there's a ischemia in the phantom, again, it's still borderline, right? Maybe the EF still stay the same even after the revascularization because it's a CTO. So I would say this indication is quite soft, and that is more important is that because as the indication is not that strong, if complications happen, then you have to be very do something more to defend yourselves. Yeah.
And thank you very much for sharing.